So I'm Trevor Roberts, and my case study was on Janice, who was a 53-year-old female, and she was diagnosed with an acute stroke, which we also know as a cerebral vascular accident. She has no other pre-existing or coexisting medical conditions, and prior to her stroke, she was living independently with her husband in a single-level home. For work, she was a musician where she composed and performed her own music, and she liked to maintain an active lifestyle by gardening and socializing with friends and family. So, for the medical description of her disease, she had an acute ischemic CVA to the left internal capsule. To fully understand what all that medical terminology really means, I broke down a few of the words to have a better understanding. So, an ischemic stroke is one in which the damage was caused by a constriction of blood flow, most commonly due by a blood clot. And since the damage was at her internal capsule, we can assume that the constriction occurred at the middle cerebral artery branches. And then the internal capsule is a white matter structure that contains axons, and those run through the basal ganglia. And now, so due to the nature and location of her CNS damage, this has led to two primary neuromuscular impairments: right sided hemiparesis and spasticity. And remember, so since her damage was on the left side of her brain, these are going to be exhibited on the right side of her limbs. Additionally, these primary impairments have now led to secondary musculoskeletal impairments, such as increased muscle tightness, decreased joint range of motion, and joint pain. So for my conceptual framework, I had three different components. So for starting off, the organization of everything will be done by using the APTA model of practice, which is great for Janice because it has 5 sequential but iterative elements, which basically what that means is that yes, we're going to follow the order seen in that bottom bullet point, but all of those components essentially work together and are intertwined, as can be seen in this picture right here. And that's perfect for Janice since she has such a complex disease or disorder. But when I'm trying to make the decisions for what assessment tools and therapy exercises I'll choose for Janice, I'm going to take some different approaches. So the system, for example, the systems model approach is great because it considers her individual systems and then the changing tasks and environments. And then the task-oriented approach is really useful because it considers a multitude of things, such as evaluating functional activities and participation, qualitative description of movement strategies, quantification of underlying impairments, and contextual factors. Oh yeah, and then I forgot I'm also going to use an evidence-based clinical practice to help strive in my decision making for those therapy exercises. For her balance assessment, I took a systems approach, which was just previously explained in the last slide, so I'm not going to go over that again. But in no particular order, one of the first assessments she can do is the PASS. And what this does is it examines postural control when trying to maintain or change a sitting or standing position. And she scored an 8 out of 26 on this assessment, basically saying that she's at an increased risk to fall. She can also do the AMPAC, which is another stroke-specific assessment, except this one measures patients' activity limitations via two short forms: basic mobility and daily activities. She scored low on both of these, not making the cutoffs, suggesting that she's at an increased risk to fall and has poor mobility. And those two things are basically leading her to have decreased abilities in participating in her activities of daily living. She'll also do the modified functional reach test, which is great for stroke patients during their early stages of recovery, as seen in this picture, because it's done in a chair. But when she starts reaching the ceiling effect on that test, I'm going to have her move on to the multi-directional reach test. But for now, when just looking at her scores on the MFRT, for both forward and lateral, she scored pretty low, indicating that she has weak postural stability and can be at an increased risk to fall. And then lastly, she can do the BEST test, which examines multiple aspects of postural control, and per usual, she scored low on this one, suggesting that she's at an increased risk to fall because of her poor postural control. But what this one also showed was that she has poor mobility, as she scored low on the gait category for this assessment. For her mobility assessments, I took a task-oriented approach, which combined the ICF model and a systems framework. These first two tests are an asterisk, and that's because, yes, I did just talk about them in the last slide because they were mainly used to assess balance, but they also had some mobility components to them. So for the sake of time, I won't go over their scores and meanings again. But these new additional tests are mobility specific tests, and again, I'm going to be talking about them in no particular order. But starting off with the tug test, she scored over 18 seconds, indicating that she has poor mobility and is at an increased risk to fall. Stops walking when talking. This test is done by having Janice start walking, and then mid-gait, I'm going to ask her a question, and if she has to stop walking in order to answer my question, this is a poor indicator suggesting that she can't handle dual task requirements, and that ended up being the case since she failed the assessment when I performed it on her. And the gait assessment rating scale, which is a really good gait observational analysis tool, which is broken down into 3 different categories: general motion, lower extremity motion, and upper extremity motion. She scored high on all 3 of these categories, which is a bad indicator because more points are given to the worst descriptions of those categories. So in summary, what that all meant was that she has an abnormal gait pattern, and this is increasing her risk to fall when she's trying to be mobile. For my short-term goals, I made these out to be what we know as our functional goals. For balance, Janice will be able to stand on a firm surface without assistance for 5 minutes by her 8th therapy session. For mobility, Janice will be able to walk 5 meters and return back to the start with minor assistance in under 45 seconds after 4 weeks of therapy. And Janice will be able to walk 10 meters and step up and over a 6-inch box with assistance and proper body mechanics after 8 weeks of therapy sessions. For her long-term goals, I made these out to be her disability goals. So for balance, Janice will be able to compose her music in a dimly lit theater for 1 hour after 3 months of therapy. And Janice will be able to attend a dinner party without sitting in a loud room that has carpeted floors for 2 hours after 5 months of therapy. For mobility, Janice will be able to walk around and water her entire garden under her husband's watch within 10 minutes after completing 5 months of therapy. So moving on to her rehabilitation exercises. These first set of exercises are going to be aimed at fixing her underlying impairments. So for paresis, we can use some strength training. For improving her lower limb strength, we can have her do some seated hip flexions with the hold, knee extensions, and toe and heel raises. And then lying down on her back, she can do some heel slides, hip abduction adductions, or glute bridges. And then she also can do some sit to stands. For improving upper limb strength, she can do unweighted bicep curls and shoulder abductions, and an exercise called water bottle punches, which essentially is, for this exercise, you just try and make a fist and then push a water bottle across a table. And what that's working on is elbow extension, or in other words, her triceps. Now, these exercises are all great, obviously, for increasing her strength, but research shows it's not very good for increasing her function. So when I'm trying to increase her strength and function, I will use functional electrical stimulation because that's what research has indicated towards, and I'll put those on her body to induce those lower limb and upper limb movements listed on those bullet points right there. And to decrease her spasticity, joint approximation has been found to be very useful, so I'll use manual compression on her wrist and ankle joints. And sensory re-education exercises to increase her somatosensation. And these will increase in intensity by going from detection to discrimination to quantification. When determining her balance exercises, I decided to have them target the 3 postural control subsystems. So to improve steady state balance, we can use a mirror or somatosensory feedback exercise. The mirror one is done by vertically placing a strip of tape down her shirt and then one on a wall and then having her line that up. And then the somatosensory one is done by placing some type of object vertically up on a wall and having her feel that with her back. Now, for both of these exercises, I'm going to give her knowledge of results, but only intermediately. To increase reactive balance, I can perform some external perturbations on her, which will gradually progress and increase in intensity by changing up the task or surface. And to make it more functional towards reaching her goal of getting back to work, what we can do is have her produce some internal perturbations herself by waving her arms and hands around as if she was composing one of her own concerts. And to increase anticipatory control, we can have her do some reaching and lifting exercises, which again, this will also increase in intensity by changing the task, such as moving from sitting to standing, having to lift up different objects, adding dual task or perturbations. For her mobility exercises, I thought she could start off doing some mere visual feedback training to help fix her underlying impairments, because there's also research out there suggesting that it can increase mobility in stroke patients. And then overall, I took a whole practice approach, so I'd have her do body weight support treadmill training, because there's a lot of research out there suggesting that it has high efficacy for improving mobility in stroke patients. But when she starts really progressing, I wanted to move on to do something more functional, like practice walking with a watering pot and bending over and flexing at the knees to pretend as if she was gardening one of her own plants. And that's going to be super useful because I just want her to strive towards reaching those long term disability goals that we set out in the beginning. Alright, and lastly, her post rehabilitation discharge plan. What is she going to start doing when she's not working with me as much? Well, I basically want her to continue and progress in those previous strength and balance exercises we were working on. So, for strength in her lower limb, she can do some sit to stands, glute bridges, wall sits, lunges, and/or squats, obviously with some type of balance support to ensure safety, and standing toe raises. For her upper limb, she can do either dumbbell or resistance band bicep curls, tricep extensions, and shoulder abductions. And then she can also do some push ups on her knees. And then I also want her to continue and progress in those external and internal perturbations, obviously done via her husband's assistance. So I would obviously have to instruct him on how we can conduct those in a safely manner and make proper progressions. And then also I want her to continue in those reaching and lifting exercises, and her husband can help progress those activities by adding perturbations or dual tasks during them. The more so new and additional exercises are going to target her mobility, since around this time she should start seeing significant improvements in her overall abilities. And before going over these, it should be prefaced that these are all going to be done under her husband's assistance or watch to ensure safety. So she can practice walking up and over step boxes to help her with things like walking up and down stairs or making curb transfers. She could practice making hardwood to carpet transfers under a dimly lit room. So she can practice making walking transfers on the different types of surfaces. And then working under that dark light is going to really help tax that visual dependency she developed from her paresis. Furthermore, I want her to work on her dual task abilities, so walking and talking, or walking with a cup of water and trying not to spill it. And then she can also do some tandem walking to just increase the overall intensity and work on postural stability while walking. But lastly, she should really just start doing some more real life or functional exercises so we can have her get back to living her normal life and performing those ADLs. So she can practice gardening her garden. And then basically, I want her husband to slowly release the amount of assistance that he has to give her so she can start doing that on her own. And she can practice composing or performing her music while standing. And if you want to make it even more difficult, she can try and compose or play one of her instruments while walking. But other than that, that is it.